Great. Good morning, everyone. My name is Ted Tenthoff. I'm a senior biotech analyst at Piper Sandler. So, as you probably know, diabetes is characterized by the loss of functional pancreatic islet beta cells that produce insulin. Type 1 diabetes is primarily an autoimmune disease in which the immune system destroys the patient's beta cells. Type 2 diabetes, in contrast, is marked by progressive beta cell dysfunction due to metabolic stress, insulin resistance, and inflammation. According to the CDC, there are more than 38 million Americans have type 2 diabetes and over 2 million Americans have type 1 diabetes, and these numbers are obviously growing. While there's been significant therapeutic advances for type 2 diabetes over the last several years, several decades, type 1 diabetes has largely been neglected, and we are now starting to see growing interest and development for new therapies for T1D. Several companies are developing novel cellular therapies to actually replace insulin-producing cells. Other novel approaches like Menin inhibition are also showing promise. I'm pleased and honored to be joined by Dr. Rohit Kulkarni of the Harvard Medical School and the prestigious Joslin Diabetes Center to review the latest in type 1 diabetes therapeutic development, especially on the heels of the American Diabetes Association meeting down in New Orleans last weekend. Dr. Kulkarni, thank you, sir, for taking time out of your busy schedule and your important work to join us to talk about these advances today.
Yeah, good morning, Ted. It's a delight to be here. So I'm excited and, delighted to share thoughts on where we are with type 1 and type 2.
So perhaps you could start off by describing what types of patients are treated at the Joslin Center and maybe a breakdown between type 1 and type 2 diabetes.
Yeah, as you rightly noted in your opening statement, the type 2 individuals, patients with type 2 diabetes, are numerically larger than individuals with type 1. And I think the ratio approximately is 90 to 95% of type 2 and then 10 to 12% of type 1. But I want to emphasize that the number of cases of type 1 diabetes has gone up steadily over the last several decades. We thought that it was much more prevalent in the Scandinavian countries and when I was in medical school, but that now has progressed to multiple countries across the world. The second caveat to that is that we always thought type 1 affected children of younger age, but now we also see that some aspects of type 1, and in fact even just classical type 1, can occur in adults too. So that is a disturbing trend.
Yeah. To that point, when is type 1 diabetes typically diagnosed and how is it diagnosed? Is there a cause or a trigger that sometimes causes it? And what is the symptomatology between type 1 diabetes and type 2? Obviously, the causes are different, but do the patients experience different forms or different symptoms?
Great question. So typically type 1 diabetes occurs in children predominantly, although as I mentioned, some forms of type 1 can also occur in older individuals, like, 8, 10, 12, 14 years. And a type of type 1 called latent autoimmune diabetes can also occur in older individuals, which has all kind of symptomatology similar to type 1. But coming to the symptomatology, we still don't understand the cause of type 1, right? So I think genetic factors, environmental factors are both implicated, continue to be implicated. There have been discussions about, cow protein being irrelevant, viral infections being triggers, but those components have not conclusively panned out. And so we're still struggling to find out what exactly are the causes of type 1, and that results in a difficulty in understanding the therapeutic approaches, right, understandably. So type 1, the patient can present with, when there's overt hyperglycemia. It could be a child who's having a difficulty in performing at school, having potential infections, but sometimes just the diabetes is so overwhelming and undiagnosed that they may come with ketoacidosis very severe hyperglycemia. Type 2, on the other hand, is a more gradual onset. So people who are overweight, who have poor dietary habits and poor exercise habits, develop tiredness, increased urination, generally speaking, generally feeling unwell. And when they go to the clinic, then the HbA1c is elevated and the glucose levels are elevated. So it's a more gradual onset, but type 1 can be very sudden and symptomatic.
Yeah, that's really helpful. So I'm going to primarily focus our conversation on type 1 diabetes today, just because there's so much to cover. And if we included type 2, it would take probably a couple hours or a whole day to talk about it. What is the current standard of care for type 1 diabetics? What are you prescribing to patients?
So type 1 diabetes patients have almost always been dependent on insulin. As we all know, the beta cells are dying as a result of an autoimmune attack. And the question is, how do we detect it early and how can we limit it? And those questions have been a major focus and challenging for us. So a patient with type 1 diabetes has to be on insulin replacement. You have to replace the lost insulin. But a recent observation of a drug called Teplizumab, which you might have heard about, has been introduced in the market over the last few years after a considerable amount of work. And that has been able to delay the progression from stage 2 to stage 3. So there are three stages of type 1 diabetes. Type 1, stage 1 is when there's no symptoms in the individual. Potentially, there's identification of autoantibodies. There is a family history of type 1 diabetes. Stage 2 is when there's more than 2 autoantibodies are positive, but the individual still has, a mild hyperglycemia. There would be some oral glucose tolerance or HbA1c abnormalities. And stage 3 is when you have overt hyperglycemia and diabetes. So teplizumab has been proposed as delaying from stage 2 to stage 3. And that we think is a very important development in type 1 because we have never had anything other than insulin replacement for these patients.
Yeah, really, really important. Can you tell us how is it that Tzield or Teplizumab works? And are you using it? Is it something you're finding effective in the clinic?
So teplizumab is a drug which acts on the T cells. So just to step back a little bit, we know that there are autoreactive T cells, so-called because these T cells, which are CD4 or CD8 positive, as we call them, have the ability to attack their own cells in the body. And in this case, it's the beta cells. So what teplizumab does is that it binds to the CD3 receptors on these T cells and then deactivates the autoreactive T cells. And secondly, it also enhances the expression of what are called as regulatory T cells, which help the beta cell. So these two effects will then prevent the autoimmune system to kill the beta cell. And this has been shown very, very nicely in multiple groups and multiple systems, and that can prevent the death of the beta cell. So coming to the treatment options, the Joslin elsewhere, it has been proposed that this can be given to individuals over a year old. But at the Joslin, we see individuals who are in the adult state. So most of the patients seen in the Boston Children's Hospital and those individuals who are given teplizumab at later ages can also be part of the system. So at the Joslin, we do slowly increasing numbers now who have been given type 2, the teplizumab. But Children's Hospital is probably where the more action is occurring. But I must say that teplizumab has become an important arsenal in our repertoire to handle type 1 in addition to insulin.
And are you seeing it as effective? Are there any side effects that we should be aware of or patients that maybe it doesn't do as well in?
Yeah, it's maybe it's a bit early to say. You always need large numbers, right, to really begin to see what are the side effects and how exactly it might be working. So I think that this is a 14-day infusion, which is given by intravenous route. At least from my knowledge, the number of side effects have so far been minimal, and so I think that the challenge continues to be that it's important for a small pocket of individuals, which is from stage 2 to stage 3. So what happens to those individuals in stage 3 and long-standing type 1, and how do you reverse it? They still have to go back to insulin replacement therapy.
And I did just get a question from the audience. I want to recommend, I think there's a Q&A box maybe at the bottom if anyone has questions. This question is, Dr. Kulkarni, when a short course of treatment, I think for teplizumab restores some beta cell function, what does the evidence say happens after the drug clears? Does the gain persist over months or regress back towards baseline?
Yeah, that's an important question, and I think the answer is that it's a mixed bag. So if you look at the C-peptide levels, once the drug has been cleared, there is a decrease in there is a higher C-peptide persistence compared to those individuals who are on placebo, which is favorable. Obviously, it suggests to us that then the beta cells are being preserved for a period of time. But as this progresses over a period of time, the decrease is in parallel. So the placebo, the C-peptide is going down. The teplizumab-treated individuals are higher, but they're also going down, but albeit higher. So even to the end of the follow-up period, the C-peptide levels are a little bit higher than the placebo, which gives us reassurance that the beta cells are being preserved. So I think that we need to really wait for some additional evidence to exactly understand how exactly or how effective it is in preserving the C-peptide. But I must add that what we also want to see is an increase in C-peptide, hopefully, and that we have not observed with teplizumab.
Yeah, great question. And then I've actually got two more, and these are all sort of on point with teplizumab. So if this kind of regenerative therapy works, but only in some patients, do we know what defines a likely responder? Residual C-peptide, how insulin deficient are they? Do they have a longer disease duration? Do we know what's kind of breaking out a responder versus maybe non-responders to teplizumab?
Yeah, these are challenging questions, right? Because the reason I say that is because of what we have learned from decades of studies using immune therapies. We've spent several $billion in $30 to $40 billion on immune therapies for the last several decades. And although if you look at the responses in the various trials, it's clear that some individuals respond, but as a group, we see that the response is kind of blunted. So at the end of each of the trials, we don't reach statistical significance in that context. So why is that? The reason is because each individual is heterogeneous. Not all type 1 diabetes patients are similar. So that's because the etiology is different, the type of cell dysfunction is altered. Having said that, the ultimate endpoint is beta cell death, but the way to get to the beta cell death is different in each individual. So the question in the case of the teplizumab is we are addressing it at an earlier stage. So there is clearly some data to suggest that if that stage 2 can be detected early and we can intervene early, then there would be some beta cell preservation. The question is, how long does it last? If the CD3 cells are being bound to teplizumab, if there's some other mechanism that comes in to then begin to attack the beta cell, then the teplizumab effect might be not appropriate. So overall, we think that the heterogeneity of the beta cell response in different patients is governing how we look at the output of different treatments.
That's really helpful. Another question, actually, I'm pleased to be getting questions from the audience. How are the GLP-1s used? Obviously, they've had massive success in type 2 diabetes and with obesity. How are they being used in T1D? And is there a niche still for a regenerative oral agent in this kind of GLP dominated world?
That's such an important and very timely, important question that all of us think the answer is yes. So, as we have looked at the GLP-1 making waves in the therapeutic world, we are beginning to learn that there are some limitations too, right? So GLP-1 initially is working very well, but clearly there's again a pocket of individuals who are responding to it, so-called GLP-1 resistance in those individuals. The second component of the GLP-1, which, I mean, we don't want to go into that, but there are people who just get off GLP-1 because of the mild side effects. Now, the important question here is, can we add on something else with the GLP-1, which can make the handling of the GLP-1 at a lower dose, right? So leave the GLP-1 at a lower dose, add on an agent like a regenerative agent of the beta cell on top of it, and then get advantage of both components here. So on the one hand, the GLP-1 is lower, so the side effects are lower, so the compliance is higher. On the other hand, then you add on the beta cell component, where we know that there are other compounds coming out for regenerating beta cells, which can push the beta cell proliferation. Combining these two would be amazing because it would have these effects which suppress the side effects of GLP-1, but then also pull up the root cause of diabetes, which is beta cell deficiency. And so if you can push the proliferation of beta cells just that little bit, then you're really handling both components very effectively. So many of us think that it's high time that we have a therapeutic approach where you have the GLP-1 receptor agonist and a beta cell proliferation agent in those individuals who are failing GLP-1 especially.
That's really, really insightful and very interesting. One other quick question, sort of more for the regulatory side. What are your thoughts on the FDA stance towards C-Peptide being a sufficient endpoint for approval for disease-modifying therapy in stage 3 type 1 diabetics?
Yeah, I think the FDA, in terms of the readouts, right? So you're asking about the readouts, and we know that in an ideal world, we'd like to look at actual mass of beta cells. And that has been a holy grail for us endocrinologists and specialists in diabetes. If there's a way that we can measure beta cell mass by scanning or some other marker and get it before, during, and after diabetes diagnosis and during therapy, that would be ideal. We are not there yet. And so as a surrogate, we have to rely on C-peptide. So before, during, and after treatment, follow up C-peptide levels in these individuals as a measure of beta cell function and slash beta cell mass. But there could also be a dynamic response. So you give the individuals an oral meal, like a mixed meal tolerance or an oral glucose, and then measure the C-peptide. So the dynamic response that you get before and after treatment will give you how well the beta cells are being preserved or whether the beta cells are proliferating in that individual. The third readout, which also is relevant, is time and range. So glucose for all of us should be in range because it has to prevent complications. So after therapy, if the glucose continues to be in range, that would be great because irrespective of the mode of treatment, ultimately we want the glucose to be in range of the normal scenarios to prevent complications.
Yeah, that's really very, very insightful. Makes a lot of sense. So as I mentioned in my opening remarks, there really was quite a bit of type 1 diabetes data at ADA over the weekend. One of the more interesting presentations I saw was the covalent 112 data on the first-in-class oral menin inhibitor, Icovamenib from Biomea. Firstly, what can you tell us about this unique mechanism of action of menin inhibition as we've been talking about preserving beta cells?
Yeah, so, my lab has been working on beta cell growth factors for the last 2.5, 3 decades. I'm giving my age away there. But trying to find a growth factor for human beta cells, especially an endogenous growth factor or something which is given orally, would be fantastic, because the root cause of all forms of diabetes is a deficiency in beta cells or adequate beta cell mass. And so in that context, if one looks at the literature, if you look at pregnancy, right, studies have been done in rodent models, but we have strong evidence to suggest that it also occurs in humans. During pregnancy, the woman is handling a slightly increased body mass because of the fetus, and so there's slight insulin resistance, albeit still in the physiological range. But the bottom line there is that that woman has to have a higher beta cell mass to maintain the glucose within the normal range. And guess how that happens? In the normal scenario, menin is a scaffold protein which is present in all cells and is present at a specific level. During pregnancy, menin gets inhibited endogenously because of the lactogenic hormones. And once menin gets inhibited, it allows beta cells to proliferate. It goes into the G1, G2 cell cycle, increased number of beta cells. And so during pregnancy, which is a physiological phenomenon, the menin gets inhibited, beta cells grow. After pregnancy ends, the menin goes back to normal levels. This is a remarkable observation because it tells us that this effect is physiological, number one, and number two, it's reversible. So some companies have taken advantage of this observation and developed molecules which can inhibit menin. And Biomea, obviously, you might have mentioned that Ted is the presented data at the ADA, and I've been presenting for the last several years. And I've been part of their scientific advisory board, but I'm discussing everything that's in the public domain. They've used this inhibitor to show that if you have individuals who are being treated with this menin inhibitor and follow this glycemic control, remarkably, they have better glycemic control for a long period of time. The second point I wanted to make before stopping is that the treatment period is just 12 weeks, right? Mm-hmm. So you give this for a 12-week period, take away the medication, and then you follow the HbA1c over a period of time. And amazingly, these individuals, even up to 52 weeks, are showing an improved HbA1c. Now, if you look at many other medications, when they stop therapy, the HbA1c starts crawling back up, and up, suggesting that the control seems to be lost over a period of time. But the effect of the menin inhibitor appears to be sustained for a long period of time.
Yeah, this is really great. I want to come back to that short course of therapy in a minute. One of the things that kind of stood out to me from the Covalent study is they enrolled stage 3 type 1 diabetics in really kind of two different cohorts, two different, what I would define as sort of two different patient populations. First, patients who had been diagnosed within 3 years of diagnosis of disease with C-peptide of greater than or equal to 0.2 nanomolars per liter. But then they also enrolled a separate cohort with patients who have had disease longer for 3 to 15 years with C-peptide of greater than or equal to 0.08 nanomolar per liter. So again, a lower sort of baseline C-peptide. These patients were treated with 100 and 200 mg Icovamenib. As you mentioned, 200 mg cohort in cohort 1, the more recently diagnosed patients, they had a 52% increase in C-peptide at 12 weeks and a reduction in HbA1c of 0.6%. And as you mentioned, importantly, this had a lasting effect where those patients who received 200 mg Icovamenib showed a 7% decline in C-peptide at 52 weeks versus 47% on historical control. So again, follow-up wasn't controlled. Do you see a difference in these patient populations between sort of the newer, maybe higher baseline C-peptide and the longer duration patients? And is there something we need to be aware of in terms of how we're looking at those stage 3 patients differently?
Yeah, it's possible that, clearly, intuitively, one can argue that as the duration goes on, the number of beta cells keep going down in patients with type 1, right? So those individuals would show a reduced level of C-peptide. But having said that, we now know from the medalist group of patients, so medalist is a study done at the Joslin where individuals have more than 80, 90 years of type 1 diabetes. And when they pass on, unfortunately, they do donate their pancreas for study. And studies at the Joslin have suggested that even these individuals have remaining beta cells which are attempting to replicate. So, the medical textbook concept of type 1 that all beta cells are lost in type 1 diabetes is not true anymore. It's very clear that even in long-standing type 1, there is a small fraction of beta cells which are still trying to replicate and to produce insulin. So going back to your question, there's no doubt that early onset, when you detect a patient very early on, the number of beta cells are still substantial, very clearly, in a majority of the individuals, and they would certainly benefit from a factor which can push their beta cells to grow a little bit more. But even in those individuals who have low C-peptide and longer duration of type 1, there continues to be a fraction of those individuals who might respond to therapies like the Menin inhibitor, because there is a fraction of beta cells we can still respond to that. But add on to that another autoimmune component. So let me emphasize also that we do agree that the autoimmune component is important in type 1. But what has been lacking is combining an autoimmune therapy plus a beta cell proliferation agent. Now, that combination has not been tried, and it's about time we do it because most of the spotlight has been on immune cells. I mean, it's like that street lamp. You're standing under the street lamp and just focused on the immune cells. But look, just a little bit away is just the beta cell standing by. So I really think that we need to extend this, especially in the individuals who got a longer duration platform.
Yeah, that's really helpful. And so back to that comment about this sort of pulsatile dosing, and if you think about it, even the underlying pregnancy is sort of a termed period, right? So is 12-week course enough? Do you think we need to evaluate longer duration dosing? Is this something where maybe patients get it for a little while, go off, get it for a little while in the future? How do you sort of see this maybe being best applied?
Yeah, that's an important question, and I'm afraid I have to give you a multi-pronged answer to that, just to set the stage. The reason being that it addresses 2 or 3 important points, Ted. One is, what do we know about human beta cell proliferation? What are the dynamics? So we know that human beta cells divide very, very rarely. So we all reach our beta cell, so-called beta cell cap by about 10, 15 years old. And then the beta cells begin to plateau, the total mass. But still, there is some slow division of these beta cells as we grow older. And as shown by the medalist study, which I alluded to earlier on, patients with type 1 still have the capacity to divide even when they have 80 years, 90 years of type 1 diabetes. So that tells us 2 important things. One is that we agree that the beta cells reach their mass very early on, but it still has capacity to divide. So why not use the capacity to divide by pushing the proliferation of that small group of beta cells which are still there? The second part of the answer is that different individuals have different capacities to push the beta cell growth, right? So we are still scratching the surface here, but it's possible that different individuals have, people with beta cell deficiency may have that particular window where they begin to show a response much greater. Those individuals who still have some beta cells, the pool may be smaller in terms of how you want to push the proliferation. So coming back to your original question, is this 12-week period enough to push the proliferation? And then you have to go back again. That question has to be answered by doing the experiment. But we now know that just 12 weeks of therapy is able to maintain HbA1c even up to 52 weeks. That's a remarkable finding from my perspective. And so just imagine if they get gone to another 12 weeks in year 2, another 12 week in year 3, and they maintain, more importantly, time in range in HbA1c, that would be a spectacular finding, because this is an oral drug, for example, and the individual can take it for 12 weeks and then maintain his lifestyle, what we think is handling the beta cell time in range. So I think that doing that experiment would be fantastic, and that's, I think, some of the newer trials will address that question.
It's really, really helpful. I'm gonna kind of ask 2 additional questions and sort of incorporate some questions that I've been getting from the field. On safety side, so far Icovamenib, and this is not just in type 1 diabetics, but also studies in type 2 diabetes, has actually been very well tolerated with only really grade 1-2 AEs, no treatment-related discontinuations. Menin is a tumor suppressor gene, as I understand it, MEN1. And I think there even is maybe a syndrome where it can actually cause tumors in or insulinomas. So if the drug regenerates beta cells, or because of this, does lifting that brake cause any real world tumor risk? So what have you seen from the safety? What are your potential concerns about menin inhibition?
Yeah, so if you look very carefully at the safety profile, it's very well tolerated, right? Because I think that even this menin has been used in other indications. So overall, the safety profile has been remarkably favorable for the patient. But going back to your other point about, what happens if you block menin, and, is it possible that it could have tumors? But let's step back and just look at the mechanism of action. So the effect of the inhibitor is not completely blocking the menin effect. It's suppressing it. So there's a difference, right? So that is important to consider, because if you're completely blocking it, or what happens in these mutations, then you're having a more significant effect of that menin pathway. So here you're just partially suppressing it. So I think that's an important caveat to that. And secondly, this is a short duration. You're just talking about 12 weeks, not like years and years of therapy, like what we see with insulin, right? With insulin, Ted, I don't know if you know that insulin is a carcinogenic, right?
Absolutely.
People inject themselves with insulin every day. And we know that insulin promotes carcinoma, all those pathways. And yet people never question that, because that's something that's not coming to their mind. But menin, because of the label, appears to be in that context. But these are the 2 points to consider, that you're not completely blocking it, and the duration is short, and the safety profile has been very, very favorable.
Yeah, it's such a great, I really appreciate that view and that perspective. It's super helpful. So I believe one of the things that Biomea is planning to do is conduct a phase 2 study in 40 stage 3 type 1 diabetics to receive titrated Icovamenib, as well as a JAK inhibitor, which I think is very interesting. We know Lilly's conducting the phase 3 barricade trials of baricitinib. Does this combination make sense to you? And kind of bringing in a question from the audience, if menin inhibition is regenerating beta cells, if you don't address autoimmunity or inflammation, won't the immune system just simply destroy those new cells? So it really seems to me like this combination could make a lot of sense, but I'd love to get your perspective on that.
Well, yeah, I think you're right, Ted. I mean, we should reverse our spots here. I think you made the right points there. So clearly, the effect of menin would push the proliferation to go, let's for the sake of this discussion, 1 to 2% or maybe 5%, right? So let's say you've got a new beta cells coming up. And clearly, as your question posited, what happens to the autoimmune attack? Is it going to push the beta cells to begin to kill them? It would, in theory, yes. But the fact remains that it takes time for these beta cells to die. And so during that period, the glycemic control is getting back to normal. But we have to remember that our objective is to keep the glucose in range, right? As much as possible to keep glucose in range. So let's now think about the second scenario where you add the menin inhibitor, but then you add another component to that, which is the autoimmune inhibitor, right? So something else which impacts one of the pathways which is purported to have an autoimmune effect. I mean, the JNK inhibitor is great. I mean, that combination in my reading would be beneficial because you're targeting two separate pathways. On the one hand, you're making sure the beta cells are being supplied. On the other hand, you're really blunting the autoimmune attack. So the beta cell will survive for a longer period of time. And ultimately, the goal is glucose in range, right? The glucose in range is what we ultimately want to do. So this combination therapy would certainly have a beneficial effect in the class of individuals where the autoimmune system is playing a very, very significant role.
Yeah, that's really incredible perspective, and we'll be super excited to see that study initiate and then data from that in type 1 diabetics in terms of combination. I believe it's a 4-arm study that's actually looking at each individually and then also the combination. So that should be a really rich data set. So I'm going to switch gears a little bit. Another promising approach that we mentioned earlier for T1 diabetes are actually stem cell-derived beta cell replacement therapies. This approach builds on decades of cadaver islet cell replacement. Perhaps you can start out by describing the history and this clinical success of cadaver islet cells. I know that, what are some of the pros and cons of this approach?
Yeah, that's an important area in the field right now. So we've been, I've been in the field since the 1990s. And so we know that we've struggled initially to do transplantation of isolating islets, first of all, from human islets. We knew historically that pancreas kidney transplants were very beneficial in individuals with diabetes. That was what pushed some of us to think that, islets would be important. And if you remember, the Edmonton trial clearly showed us that if you isolate islets and you transplant them, you do get insulin independence. But however, clearly, immune suppression is an important component there. So that caveat still continues to plague us, right? So we've achieved remarkable progress in making stem cell-derived beta-like cells. We call them by different names. But what is clear is that we can take a blood sample from a living individual. We can make beta-like cells from that individual. We can put them back into the patient and this starts secreting insulin. That has been achieved. But there are two other caveats with that. One, of course, is that these individuals, if it's all allogenic, will need to get chronic immune suppression. And that is not a desirable component of that for that individual, clearly, because it's got so many side effects. The second point, which is important to consider, is are we going to just put beta cells? Or what about the islets? So the individual is lacking a balance between the beta cell, alpha cell, delta cells, because the islet contains all these different cell types for optimum glucose homeostasis. By just putting the beta-like cells, you're skewing it only towards the beta cell in terms of the regulatory component. You're forgetting about glucagon and the other cell types. And why is it important? It's important because hypoglycemia is a very important side effect for individuals with type 1 diabetes. So we have to address potential causes of hypoglycemia. And we know that glucagon, which is produced by alpha cells in the islet, is very protective in the context of hypoglycemia. So the field is thinking maybe we should be making whole islets to put into the patient rather than just the beta-like cells. So where we stand with all the approaches right now is that immune suppression continues to be an important caveat for these approaches, and we have to address that. And I guess you're going to ask me a question next is, there are approaches by some companies where they're trying to make this hypoimmune, right? So you make the cells, the starting cell hypoimmune, and then you make the beta-like cell, and then you transplant them, and you put it into the body. Then because of the hypoimmunity, then the beta cells will not get attacked. So that is an interesting approach. But what would happen if the individual gets a common cold or a common viral infection or a bacterial infection? are we creating another problem for those individuals by preventing the beta cell autoimmune attack, but making them susceptible to common colds and infections, where people can stave it off very comfortably because of the immune system in the body? So we have to think about how we want to prevent one complication, but not by adding another complication in top of that.
Right. Okay, so I want to kind of unpackage that a little bit more, if I may, because one of the first approaches, it feels like the field is kind of advanced stepwise here, whether it's engraftment, again, around this core issue of host rejection, but some companies have used engraftment. Now, part of the factor too, from what I understand, is that there's just a very limited supply of islet cells, and that kind of limits it as well. And maybe you can tell us if it's more the supply or more the lifelong immunosuppression issue. But I believe that this is sort of complicated history, but Vertex acquired a company called Sema in September of 2019, and then also a company called ViaCyte in July of 2022 for these technologies. ViaCyte was partnered with CRISPR Therapeutic. CRISPR and Vertex did a cross-license deal, and then ViaCyte programs were actually returned to CRISPR in January of 2024. So I think the first approach is Vertex is conducting a registrational trial now of Zimislecel. I always have trouble pronouncing that one. This was the program acquired from Sema. Now, this is an allogeneic stem cell-derived, fully differentiated, insulin-producing islet cell delivered as an infusion to the hepatic portal vein. But as we said, this is still requiring lifelong immunosuppression. So is it enough to simply augment the supply of islet cells, or is the bigger issue here still this lifelong immunosuppression, and we can move into some of the hypoimmune and immune privilege approaches in a minute?
Yeah, well, I think you're right. So clearly, it's a big step forward when they fine-tune the approach to infuse these cells into the portal vein. And that would be a great site for the transplant because of the portal system. We know that in a normal individual, the beta cells are in the portal system. So transplant site gains significance in that context. But the challenge with that approach is that you can't peep at what's happening in those cells over a period of time. So let's say a patient gets the infusion, and then 6 months later, you just want to take some samples out and see how the cells doing. Are they okay? Hopefully, they're developing into tumors. So getting a sample back at 6 months or 1 year later, is a challenge when you put it in the liver. So that's the limitation of that site. So, and quickly to add to that is that these individuals clearly need chronic immune suppression, continue to have that, and that's an individual system which is a major limitation. But the sites have changed now in that context that one can now consider putting it into the forearm, in the subcutaneous space, or potentially in the abdomen, in the muscle itself, or between the shoulder blades. And the advantages of these is that you can take a small biopsy out and then look at the samples over a period of time to make sure it's not, having any deleterious effects. But it doesn't fall in the portal system. So that's the limitation again, because normally it should be in the portal system. So these are the caveats to the site of the transplant and how, but all of these would need chronic immunosuppression. So some of these studies have also used encapsulation devices, right? Yeah. So some of the earlier encapsulation devices developed fibrosis, and that led to them not being suitable over a longer period of time. Some of the newer devices have limited that ability, but still would need to have some combine of immune suppression.
Yeah, so it really seems like immune or encapsulation has not solved this protection of the graft fully, and that there's limited long-term response because of the mast cells building up along the device. And this is really what I think has led to sort of genetic engineering through different approaches. Sandler Biotechnology is doing a study at Uppsala University with their hypoimmune pancreatic islet cells, and they're going to file an IND for SC451 this year. Century Therapeutics actually just gave an oral presentation at ADA on preclinical data on 813. These are iPSC-derived beta islet cells that incorporate Century's alloevasion 5.0 edits to avoid host rejection and the need for immunosuppression. And I think CRISPR is also kind of building on some of that early encapsulation work to develop CTX213, an unencapsulated iPSC-derived islet cell with the same genetic edits. So again, how do you assess these? Obviously, we're still very, very early and don't have a lot of clinical data yet. I think literally all three of them are still preclinical. But as you laid out this importance between the portal system, delivery, maybe avoiding immunosuppression, risk of infection or other things, how do you sort of see this evolving?
Yeah, that's an important point. And as you rightly mentioned, it's not come to the stage where we have data in patients already, right? So I think it still continues to be in very early stages. But in theory, it makes a strong case that if you can make these cells reduce the HLA-1, HLA-2, which are the major histocompatibility antigens, which are important for this autoimmune attack. If we can reduce those in these cells, right, in the stage when you're making these immune cells from stem cell derived cell lines, then that would be an advantage. And they also have, as you mentioned, use CRISPR to introduce some other aspects which can reduce this NK suppression, the natural killer inhibition, and so on. So there are approaches where people have been trying to fine-tune this by CRISPR Cas9, and it just remains to be seen how exactly it would pan out in these individuals. But the question then that I would pose is, number one is obviously, do we also have data, even if it's preclinical, how do they respond to common bacterial and viral infections? Are they able to survive? That would be great if that kind of data is available. Number two, will this kind of approach be effective in all individuals with type 1, or would it be just selective for some individuals with type 1? So, because as I had mentioned earlier on, there are different pathways which are being activated in different types of type 1 diabetes. And that's why historically the immune therapies have been so variable. Multiple immune therapies have been so variable. Some people showing a response, others not showing a response. So patient selection would be relevant in this hypoimmune approach too. And that would be important to consider. And I'd like to see what kind of patients would be targeted for this initial hypoimmune approach.
Yeah, a lot of work to do. So a lot of promise, but a lot of work to do. I have one last question for you. And again, thank you so very much for your time. This has been a really wide-ranging and super illuminative conversation. I'm going to kind of combine two. One from audience member asked, what are your thoughts on SAB Bio's immune approach? I think what they're doing is maybe using humanized bovine antibodies. It's a multi-antibody approach for type 1 diabetes. I'm not sure if you're familiar with that, but what are your thoughts on that approach? Is there anything else that we haven't discussed that's catching your attention in new approaches for type 1 diabetes?
Yeah, I think that I see that question here. So it's that SAB Bio with the ATG is the antithymoglobulin. I think that is an interesting approach because that has been shown to have a wider repertoire of function in the context of immune suppression. It would be very, very interesting to see whether that will, have an effect in a larger type 1 population. And again, patient selection becomes an important factor there. And going back to the earlier discussion, is it possible for that the ATG could be combined with a beta cell proliferation agent, which could then, on the one hand, suppress this widely, but also keep pushing the beta cells to grow, because then ultimately we want the C-peptide to go up or remain as stable as possible over a period of time, and again allow us to leave the glucose in range, because that would be the ultimate goal for us to maintain that.
Yeah, very interesting. And anything else on the horizon that you're keeping an eye on? I mean, this is really exciting times for type 1 diabetes versus the last 20 years. So anything else?
No, I think that the emerging therapies are very exciting. Having been in the beta cell field for several decades now, I'm really excited to see that finally we are addressing the root cause, right? We have to address the root cause, which is the beta cell deficiency. And in that context, I think among all the components here, the Menin inhibitor appears to have a multifaceted approach, not only pushing the beta cell growth, but also enhancing GLP-1 receptor expression, and also providing some data to suggest that it protects muscle loss. So those are early findings, but I just think that those additional components should position that one as a very important consideration to target patients with type 1 diabetes, as well as patients with deficient type 1 diabetes and those who are failing GLP-1 therapies.
Yeah, great. Well, Dr. Kulkarni, I truly cannot thank you enough. You are an absolute gem and such an important luminary in this field. So thank you for all the work you're doing. Thank you for the time that you've given us today. And we'd love to stay in touch, because I think it's going to be really exciting to see these progresses over the next couple of years, over the next decade, really transform the landscape.
Yeah, thanks so much, Ted. It's been a pleasure and an honor. I see that there are some questions also in the chat, but feel free to let me know if I can respond to those questions via you. So if you want to let me know the questions, I can send them back to you, and they can go back to the people involved. But because I'm always happy to answer questions, which are always difficult to do it in 1 hour timeline, but I'm open to being...
I tried to incorporate as many of those as we could into our discussion, but this was really wonderful. So thank you for your time today.
Yeah. Thanks, Ted. Have a great day.
Bye-bye.